Alaikum and welcome to another session on this channel where we're going to try to cover inotropes in pediatric in less than 15 minutes. And here we go. So we're going to try to, in this session, to cover for terminology related to inotropes, know the different types of inotropes and when to use each one of them. Basically, when we're saying inotropes, we're not just saying inotropes, we're basically referring to other stuff that can support the heart when it's struggling that are within the field of the same drugs. So when we say inotropes, inotropes are the drugs that would increase contraction of the heart. There are some other drugs that are called chronotropes, which are the drugs that can increase the heart rate. Dromotropes are the drugs that would increase the conduction of the cardiac fibers to the cardiac impulses coming from the SA node or whatever node. If the heart has got other nodes, that would be the pacemakers. We're going to talk about these drugs on the left hand side, which I would say the most common used drugs in the pediatric field. So adrenaline, noradrenaline, dopamine, butamine, melanone, vasopressin, and isoprotonine. And basically, if you're feeling like Homer Simpson in this picture about all of these drugs, then this talk is for you. So adrenaline is basically a drug that covers basically most of the effects that we've talked about. So it's an inotrope, it's a strong inotrope and a strong chronotrope, and it's also a dromotrope, which in a sense increases the cardiac excitability. It's your natural chemical that would that your body would secrete for the case of fight or flight situations. So it's basically covering the same natural response. So basically this also is a peripheral vasoconstrictor and a central vasodilator. So it increases the blood pressure and increases the perfusion to the central organs. It's also a bronchodilator, so it also improves oxygenation and the CO2 exchange. So it's basically brilliant, and it's the king of inotropes. Maybe more of the one of the things that make it more of a good king is the recent discovery that we can use it also peripherally. So if you don't have a central line and you've got a child that is in shock, especially septic or distributive shock, then you can use it with a peripheral line until you get central access. We can also use it for cardiogenic shocks in the same situation. So I would say always consider adrenaline as your first line in children. Then we go to noradrenaline. Noradrenaline is mainly a squeezer or a vasoconstrictor. It's also got some inotropic effect, but mainly it is a vasoconstrictor. So that's why it's highly used in septic and distributive shocks, because of the pooling to the peripheral blood vessels and the third spacing. It's also used in neuroprotection as we are trying to keep the cerebral perfusion going with some kind of high blood pressure to keep the blood going in face of the high ICP. Also be careful when you're dealing with struggling hearts, or I would say cardiogenic shock. You can't use noradrenaline alone, or you're going to add to the afterload. So be careful about that. Going forward, we are going to discuss dopamine, which was a drug that was a bit tricky to learn about when we were junior doctors, as it's got dose-related effect. So if you're going with lower doses, you possibly can just improve the vasodilation for the blood vessels going to the kidneys and the gut. If you increase the dose furthermore to anywhere between 5 to 10, then you're going to get the real inotropic effect of the drug. If you keep going forward above 10, then usually you're going to get a vasoconstrictor effect, which is going to put the blood pressure up. This also adding to the fact that it's the dopamine, no matter the dose that you're using, is always going to be a chronotropic and a dromotropic drug, which makes it a highly arrhythmogenic drug. It's not used as much in PICUs nowadays. It's still used in NICUs more often than it is used in PICUs, but that's all I can say about it for the moment. Yeah, just keep knowing about it, because you don't know when are we going to go back to any of these drugs again. Then we go to discuss its sibling, which is dobutamine, And Butamine is also a highly arrhythmogenic drug that has got inotropic, chronotropic, and dromotropic effects. But in comparison to dopamine, it's a vasodilator and a bronchodilator. It's still not also used as much in PICUs, but still used in NICUs, and mainly it is favored in cardiogenic shocks and pulmonary hypertension. The latter, pulmonary hypertension, is why I think it's used often in NICUs. I would be careful using it with distributive and septic shock, because it's going to add to the pooling to the peripheries, which is also going to add to the shock itself. Yes, be careful about that. Going forward, we're going to discuss Melanone, which is basically the wizard of the CICU science. So Melanone is mainly an inotrope and a vasodilator, something we call an inodilator. It's also a lusitrope, which is something that would relax the ventricles on diastole. And that fact is one of the reasons why it's so favored in CICUs, because of the fact that none of the drugs that we've mentioned might support the heart in diastolic cardiac failure, which is something that is hard to pick up to begin with. It's also a bronchodilator, so it also decreases the pressure in the pulmonary artery, so supports the right ventricle, which again, not most of these drugs really support. That makes it a great drug that is the first line currently in cardiogenic shock, pulmonary hypertension, and post-cardiac surgeries. And again, it's not favored in distributive and septic shock because of the vasodilator effect. Vasopressin is, well, a more potent squeezer in comparison to noradrenaline. We only use it currently, although I don't think there's any evidence base against using it earlier, but we only use it in refractory septic shock or distributive shock when noradrenaline is not keeping enough blood pressure and not supporting the blood pressure properly. Having said that, again, be careful in using it against a struggling heart. Now we go to something that I don't think a lot of people have used really, but it's still worth a mention. So isoprotonine. Isoprotonine is a mainly chronotrope. It's got some inotropic effect. Again, I think mostly the kind of support it gives is coming more from the heart rate. Don't forget that your cardiac output is all about stroke volume times heart rate. So heart rate can support things for you if needed. I think it's used mainly in cardiac units, and it's also used mainly for events where there are bradycardias affecting hemodynamic stability, until you get maybe pacing on or the heart going basically. But I don't think it's used for any other reasons mainly. And I think that's it. Oh, we managed to make it in, well, 8 minutes. Try to keep the little hearts happy as possible. And don't forget about your own heart and your own well-being. And good luck.